and Dr. Braverman, the latest on physical activity in our patients with connective tissue disorders.
Let's see. Good morning. So my name's Alan Braverman, and I work at the Washington University in St. Louis School of Medicine. I'm a cardiologist, and we're going to talk a little bit about exercise and physical activity. My father had Marfan syndrome. My oldest brother had Marfan syndrome. His son has Marfan syndrome. And my oldest brother had height in our family, of course. He was a basketball player, a weightlifter, a shot putter. He was a strength-trained athlete until we made his diagnosis after he finished high school. He just didn't know. So we're really interested in having people do activities that are considered safe and living a long life with Marfan syndrome or related conditions. Let's see. Should I direct this at some place? There we go. Okay, so really there's been a wide variability in the discussion about what exercise and what physical activity is appropriate, and then what things might be less appropriate. And just to highlight some of the way we approach this, instead of saying, you know, what can I do or what shouldn't I do, I like to begin the conversation is, what do you like to do? What's important to you? Because then we can really talk about that and how to incorporate what's important to you into what's practical, because there's so many different possibilities. In general, those with genetic aortic conditions have an aortic risk. So we have to characterize what that risk is, and it's going to be different depending upon the person, their genotype, their aortic size, the growth rate, all sorts of things factor into it. And in general, the guiding principle is to be safe and low risk and think about things in that manner because aortic properties. But I think the key point really is to emphasize how important that low impact, recreational, aerobic exercise performed in a moderate manner is safe for the majority of individuals who have genetic aortic conditions, whether it be VEDS, whether it be Loeys-Dietz, or whether it be Marfan, with, of course, individual characteristics being very important. Some people have ocular, cervical spine, lung, feet, other features that we have to incorporate. That's why the individuality is very important. Juan talked about the ultrastructure of the blood vessels, so I'm not going to highlight this, except for just remember, it's the elastic tissue inside the wall of the aorta that becomes abnormal in these connective tissue disorders. And people have variability in that abnormality, some quite marked and some quite minor. And so these sort of properties give the strength and elasticity to the aorta, but also is where the aorta becomes a problem. So the normal elastic fibers here, these parallel sheets of elastic tissue, these wavy black lines on this elastic tissue stain here, all normal, 50 organized rows in the proximal aorta, and in some individuals become quite disrupted. And that's what gives the properties to the aorta that can distend or enlarge over time. And in general, the aortic wall is able to accommodate massive forces. So you can imagine strength-trained athletes doing massive amounts of weight training, Olympians, et cetera, and the aorta can handle it. Although what's interesting is what we're learning, though, is in middle age and older, strength-trained athletes with normal genetics have larger aortas than non-strength trained athletes. You look at formal professional football players, especially those big bulking linemen, rugby players, and others, when they get into middle age and older, have much bigger aortas than their normal population, but don't have any increased risk of aortic dissections as far as we know. Maybe it's adaptive. Maybe it's something to that. And maybe that property of exercise at some level may give strength to genetic aortic conditions. We're kind of learning about that. Okay, aortic risk differs. These echograms are people with aortic conditions, but this is normal and this is quite dilated. So what's the risk is going to be different between the person. So exercise and physical activity recommendations might be different and much different than the person after an aortic dissection. Okay, this is probably the most important slide really we don't really know what we're talking about is probably the safest thing to say is to say, what data do you have to show that what we're saying makes a lot of sense? A lot of it has to do with theoretical properties of the aorta and response to exercise. But we don't really have information about what would happen to somebody if they did a certain thing at a certain time at a certain level, because those studies just haven't been done. So target heart rates during exercise, what happens if I choose to do something that you might not have on your most preferred list, Dr. Braverman, and what's the outcome in that? So when patients ask me this, I have to be honest, saying like, well, we don't really know. It's really based upon a lot of theory and like what we might predict and then what could happen. And of course, we don't always have the right answer. So we have to kind of incorporate a lot of the things to the individual circumstances to come up with a plan that's going to last a lifetime. And again, we talked about this, but different people have different things that we have to talk about and share and think about with regard to exercise. For some individuals, very few of these are important. And for others, they're paramount because of problems for the feet or problems with the spine, problems with the eyes. Maybe I'm on a blood thinner because I had an artificial valve. So, downhill skiing might not be the best choice for my, because somebody might run into me, even though I'm a really good skier. So that's how that works. You have to think about these things and to come up with a plan that makes sense for the individual that they can live a lifetime with. Okay, so let's talk a little bit about exercise physiology. Why is this important? What do we know? And what might happen during different types of exercise? So these individuals are like Dr. Eagle. They're getting their 10,000 steps in. They're moving. They're doing dynamic exercise. So that's where muscles move when you walk or jog or swim. And then very little blood pressure change occurs because muscles move. It's a dynamic motions and blood flow increases, as opposed to the static exercise of this lady doing intense weight training, straining, contracting muscles against a fixed load. So that vasoconstriction leads to an increase in blood flow to fixed muscles that don't move, and there's hypertensive response. So the blood pressure response to walking is much different than the blood pressure response to fixed isometric exercise at heavy loads, not light loads, but where you're reaching muscle fatigue and can't do anything more other than grunt and bear down and push as hard as you can. And then what's the level? So these Olympians are doing what Olympians should do. They're trying to win at maximal bodily function as hard as you possibly can in training and during athletics, whether these guys are just having fun. So that you can imagine there's tennis and then there's tennis. And there's swimming and swimming, and there's weightlifting and there's weightlifting. And so you really have to say, what do you really mean? What's important to you? Let's come up with a plan that you can last, that'll work for you for your lifetime, and we'll all be confident that we think that's low risk and safe. During dynamic exercise, this is the systolic blood pressure, this is the lower number. When you do things at a moderate pace where you can still kind of talk and get along and breathe normally, blood pressure rises, but not much for most. Sometimes we have to check that because some people's blood pressure goes up a bit more if you have underlying hypertension. But just like that strength trained athlete, when you reach muscle fatigue and can't hold it any longer, the systolic blood pressure starts to rise and can be, very, very high. And we think that transmits into the aorta, although there are physiologists, cardiology, exercise physiologists that are trying to disprove this sort of thing. And so we're going to learn a lot more in the next few years about what strength training really has to do with the aorta from elegant exercise protocols that are ongoing now. So we know that surges in blood pressure can occur during intense physical activity, especially isometrics. But thankfully, although I wrote it here, dissection, that's our fear, could occur. This is extremely uncommon. When you look at large data sets like collegiate athletes in the US and say, how often does an aortic dissection occur in a collegiate athlete? It's a fraction of a very rare problem, thankfully. So that's just something we consider and have to think about for those that are identified and have risk. We can kind of estimate some of the information, and this is where a lot of the guideline comes from. You say, well, what would happen to my blood pressure if I do a certain level of exercise? Well, it all depends. Where did you start? What kind of physical activity are you going to do? How intense is that going to be? What's your conditioning? So again, the more conditioned you are, usually the lower the heart rate response and the lower blood pressure response is to that activity than somebody who's just starting out. So there's some training involved. We can kind of guesstimate or estimate how much effort's involved by using the metabolic equivalent of task. What you're doing right now earns you a MET of 1. So sitting quietly, what I'm doing, nervously talking to you, is probably a little bit higher than that because my heart rate's a little faster, my blood pressure's a little higher. But if I'm walking or jogging or swimming or climbing these stairs or walking through the beautiful city of Oslo, it's going to be more. So we can guess and estimate how much physical activity is involved by the number of METs, and you can see those in the orange compared to those in the green and everything in between. And you can imagine different levels of activity depending on how intense that really is. And then you can say, well, what do you expect for the blood pressure to change? Again, it depends on your starting blood pressure, your conditioning, how hard you're doing it, for how long, et cetera. But in general, those sort of moderate physical activities lead to a fairly modest change in the systolic blood pressure during activity. So that's why a lot of the guidelines come from what do we expect to happen if you want to do this at a certain level. Okay, guidelines are written by people who have to put ink to paper, and you can't finish until an agreement's made. And that's the problem with guidelines. Having written a few of these myself, it's stressful because everybody has to agree on it, and you have to come up with hard numbers. And those numbers then become the guideline. And one thing higher is over the guideline, and one thing less is perfectly fine. Well, life is really not like that, but that's how guidelines are that we write. So when we wrote these guidelines about competition, if you have heritable connective tissue disorder, they're very restrictive on purpose. But these are, again, competitive athletes. This is not recreational athletes. So these guidelines written 10 years ago emphasize low levels of intense physical activity for those who are recognized to have a genetic aortic condition. Now, I'm a contributor to a set of guidelines that are in review right now. They should be out at the end of this year, could be first of 2025. That are going to have a lot more information that we call shared decision making. And I can't say anything more than that about it because that's all you can say. They're on an embargo. But I think it'll be, again, very informative, interesting, and have a little bit more wiggle room depending upon the personal information. And I think really important also is a set of guidelines that are being written right now looking at we call tactical athletes. And so a tactical athlete is somebody that would be a police officer or in the military or in the Air Force, things like that, which there are millions of people that are involved in that activity that also have risk for aortic events. And some enter, of course, into middle age and older. And there's a document that's in its writing phase right now on that topic as well. That'll be out probably toward end of 2025 or early 2026. Okay, as far as what we really want to talk about, though, is again, this is for high school, college, and above, competitive, very restrictive for most activities. But what about non-competitive recreational or in younger people where forces and competition, collision is much, much less when you're child as compared to adolescent, adult, et cetera. So all the organizations, the Marfan Foundation, Lois Dietz Foundation, ACC, European Society, FASCERN, others have written very similar sort of verbiage to emphasize the importance of doing things that are non-competitive, walking, jogging, bicycling, tennis, swimming, jogging, hiking, things like that in a moderate pace where you're not overdoing it with straining yourself to reaching muscle max, etc. We don't really have a lot of information at all about collision sports, but some people, of course, collision has more risk because of either like vascular EDS might have more vascular fragility. Loeys-Dietz might have risk for cervical spine trauma. Marfan syndrome might have ocular risks, other skeletal risks. So again, you have to think about all that when you think about sports that involve really heavy collision as opposed to running into each other playing, young person soccer or American soccer. So these are the sort of things we think about in kind of coming up with plans for people when they want to live a lifetime of physical activity, which is so important. Exercise and cardiac rehab were written about in the 2022 ACCHA guidelines. Very importantly, also in the 2024 documents. Okay, what about research? Well, there is research into exercise from animal models, and this is really interesting. So this was a study that was performed almost 7 years ago now, and so a mouse model of an abnormal genotype of FBN1, so a Marfan mouse. So you could imagine some of these mice were allowed to be couch potatoes and just eat and sleep and sit around and not do much activity, where other mice were forced to run on this wheel several hours a day with different levels of the pace. They would kind of make the wheel go faster or slower to get a certain heart rate up, just like your trainer might say, go faster, etc. And they looked and said, what happened to these mice with the Marfan gene if they were allowed to sit on the couch and watch TV all day, eating Cheetos and things like that, versus the mice that exercised. And this represents higher levels of exercise. So this is kind of mild, this is kind of moderate, and this is much higher, 85% of your maximum predicted heart rate. So they kind of said, well, what would happen to different mice? Very, very interesting study. Well, this is what happened. So wild type means normal. And these were wild type mice that sat around or exercised, and they didn't really do much different as far as the rate of growth of the aorta. But the Marfan mice that sat around and didn't get to exercise at all, their aortas grew much faster than Marfan mice that exercised in a moderate way. Actually, that moderate exercise protected the Marfan mouse aorta from growth rate over time. And this exercise, when they sacrificed the mice and looked at the elastic tissue, those parallel sheets of elastic tissue, it didn't degenerate. It actually looked healthier in the mice that exercised than the ones that were sedentary. Now, once those mice reached 85%, so more intense exercise, it kind of had a U-shaped curve. So it went the other direction. They didn't do as well again. So the aorta, it was not as healthy at that higher level of exercise in the Marfan mouse. So that's sort of the theory behind, how do we recommend things? But of course, people and Marfan mice are not the same. So we don't really know about that in people. We don't have studies so much in people, but we do. So 2 years ago, the foundation supported this beautiful conference in another city not far from here, Science in Paris. So I'll highlight a few of the papers from that. We're going to learn a lot in Science in Tromsø coming up later this week. And again, this is what is so interesting and exciting to learn about the research. So you can see several presentations about exercise in different connective tissue conditions were presented 2 years ago. And some of these have made it into papers. Others have just were presentations yet. I'm just going to highlight a couple of them just to show you what you already know. This looked at quality of life and then exercise capacity in young people who had genetic aortic conditions. So the authors state again that the big worry has always been, the aorta is going to have a problem if you do this exercise. So there's very restrictive, and I think almost to a fault. We've been too restrictive on physical activity, especially in young people, right off the bat, and so that creates a lifelong of concern. So it's diverted the attention from the importance of exercise on quality of life, musculoskeletal fitness, emotional health, physical health, etc. So they wanted to look at what about this condition and what's the quality of life starting young into early adulthood, and then what happened if you did a maximal exercise test in individuals with a genetic aortic condition. So this looked at 63 individuals, again, young ages, 5 to 21 years old. They had a condition, Marfan or SVEDS or Loeys-Dietz, and they filled out questionnaires, looked at different parameters, and then did, a formal exercise test to reach maximum oxygen consumption. So a maximal exercise test to see how did that compare. And just like you might imagine, exercise capacity was only 2/3 that of the other population, even the 5 to 21-year-old people, much different than matched controls. And as again, you might think is interesting, there was a correlation between what was quality of life measures, again, self-reported, compared to the results of that test. And there was a direct correlation. So this was a very provocative sort of study looking at this and saying, well, maybe deconditioning, then the importance of deconditioning should be recognized early and should start thinking about an adapted physical activity at a young age, because that might change exercise tolerance, that might have impacts on mental, physical health, quality of life, and other factors. So very interesting. The group at Stanford did a study looking at exercise, so it's not randomized, so just an observation. They took 24 children, again, 8 to 19 years old. These were just Marfan, and they compared them to age-matched Marfan patients. So some people with Marfan were involved in an exercise program, and the others with Marfan syndrome did their usual life. And they really wanted to see what happens if we had people exercise up to 10,000 steps a day. Would that be okay? Would they feel okay? Would it affect their aorta? Would there be any concerns? So questionnaires, most were sedentary, either by choice or by parents' decree. And then most completed the intervention. And even though you're trying for 10,000, just like we do, they got 7,000 in. So it can be a challenge to be that active. And they wore their trackers. And then they said, what happened to the aorta? This was only a 6-month follow-up. But interestingly, so the rate of aortic Z-score change, that just means how quickly did the aorta change compared to what you'd expect it to change. So it actually grew more slowly than the people who didn't exercise. Certainly didn't grow faster. Very interesting. So a small study, short time span, shows the safety of this sort of a very low risk. Just be more mobile, get moving, move your muscles. So again, it's feasible, increasing activity, slow the aortic dilatation rate. And again, it's just an observation. It's not a randomized controlled trial, but again, provocative. We worked with Kim and his group from Michigan, talking about what about after aortic dissection? This is a population that has a lot of fear, and a lot of it is because they feel it from their doctors and surgeons about, be careful, don't do too much. We really impart this concern, and they read about it and learn about it. And again, I think the message after a type A dissection, lessons learned from the IRAD, is that we expect you to live a long life. That's the message. So you have to live your life to the fullest with appropriate information. Again, another study from the IRAD looking at survivors of aortic dissection. And as others have mentioned, mental health concerns very high because of concerns after dissection. 1/4 of people no longer did any physical activity. And as Kim brought up, many people are not even sexually active anymore because of fear. But in those who exercised and those who got back on track, so to speak, they had less mental health concerns and, importantly, also lower blood pressure. So again, structured exercise, very, very important. ACCHA guidelines from 2022, the recent European Cardiac Society and STS guidelines from 2024. A lot of these speakers are going to be at the next meeting. Emphasize the importance of exercise and physical activity. They're written right into the guidelines now for us to read. This is from the ACCHA guidelines. For individuals with aortic conditions, exercise and guidance provided There's certain things to maybe avoid, and that's for who've undergone surgery, the importance of cardiac rehab. Because in the US, cardiac rehab is not covered by general insurance plans, not part of it, unless you've had a valve replacement as part of the surgery. And so that's a big gap. And now we've written this purposefully so the insurance companies would read this and they would be able to get it covered to get it right back on track with exercise after aortic surgery. Those with thoracic aortic disease, blood pressure is controlled, 30 to 60 minutes of mild to moderate exercise of moderate intensity, 3 to 4 days a week. And importantly, for the first time in the guidelines, a very strong statement about screen for mental health concern, post-traumatic stress, provide education, resources to enhance quality of life. Because again, the message is you're going to live a long life. So let's make the best of it. Let's address what the concerns are so we can move forward and have healthy mental health whenever possible. This is from the European guidelines, and it's beautiful. I mean, it really mirrors the same approach on either side of the Atlantic about exercise, cardiac rehab, etc. So this was just published. Okay, clinical trial, exercise after aortic dissection. Again, this shows the importance of this topic. This is Siddharth Prakash is going to present this, I think, at the meeting in Tromsø. We participated with Kim's group in Michigan. And what we did was look at patients, people who'd experienced an aortic dissection and either type B without surgery or type A with surgery and had been 3 months out and stable, all well, etc., recuperated fine, and randomized them to either a guided exercise program or usual care and a 12-month follow-up with what happened to you, what's your quality of life, what's your blood pressure like, and what's your aorta like. And so this study is completed. We're in the data collection phase. It's a year out now, so the final publication, the final paper will be written soon. We have the preliminary paper just came out. And again, we're going to look at psychosocial impact, exercise level, etc. And the hypothesis is that mental health will be improved and physical health will be stable or better, blood pressure and aortic health. That's what we hope to see, and we'll find out with the results of this study. Okay, so really what I wanted to share with you today is really have a broad overview of the importance of lifelong movement, physical exercise, and physical activity. Important to quality of life, certainly important to mental health, lowers risks of many different conditions that will that we're at risk for a lifetime, living longer lives. And I think there's been really a lot of misinformation just because of the concern about aortic risk. And I think the pendulum's now swinging more toward a holistic approach that individualizes everybody's genotype, phenotype, etc., to come up with a prescription that can lessen mental health concerns. And a lot of the leadership has come from organizations like the Malfren Foundation and others to emphasize low and moderate aerobic exercise. In mouse models, we know that this sort of exercise protects the aorta. And Mary Shepard, who's a colleague, put this sentence into a paper we wrote, and I thought it was just beautiful. If this research in mice holds true for people with aortopathy, aortic conditioning through safe levels of physical activity and recreational exercise could potentially have favorable effects on the aorta and the potential to buffer the hemodynamic effects of the inevitable stressors that we all face and because of life and circumstance. And again, there's a lot of information and a lot of interest in exercise physiology in those with heritable thoracic disease. And I think we'll all be better for it. So let's get out there and have a lot of movement. So anyway, thank you.
Questions for Alan? Superb presentation. Yes, sir.
Being a representative of the general population, I think one of the really important part of this is how do you motivate a person to do exercise now you're in a context where you have been kind of held back. And what you are saying is that this is good for you, it's good for your mental health, and it's good for your life. But my experience is that the hardest part is actually to open the door and get out. So how do you address kind of the hinders that is hindering individuals to take good choices?
Yeah, so the question is, how do you motivate an individual? And so it's so highly variable. Some are super motivated, and it's like you've opened the gate, and others have such concern. So and as we say, it's hard to unring a bell when they've come to you already with this information that it's so risky to do things like that. So usually first visit, depending upon the person and condition, we usually say, what would you like to talk about? And then if they haven't mentioned this, because we talk about so many things, we say, like, are you exercising? And often it's a younger person with a parent, and you can see the person that you're talking to's eyes are opening up, and you see the parents just gloom come over their face because they have such worry. And so really it's an education. I think that's the first step. It's to say, where are we starting from, and then go from there to talk about, and then we say, what do you like to do and things. And other times it's a huge challenge. It's I think the most difficult part of my job ever is when I see an elite athlete that is just diagnosed. And I think that's about an impossible discussion that you have to have with that person, again, with very little information about what the absolute risk would be for that person. Like that person that said, a professional soccer player, but had an aortic aneurysm. Well, that person, again, everybody would, I think, agree with, but if the aorta was more normal, but they had the condition, what do you tell somebody like that? And how do you really have information, which we don't, that's really comes up with shared decision-making. But no, I think it's just as you said, we try to emphasize what do you like to do? What do you want to do? Come up with a plan. I joke about this, but at the Marfan Foundation Family Conference, they'll have a group of kids in the room. There'll be 100 or so kids, and they'll put somebody like me in there and say, like, talk to these kids. And I go, okay. And I always ask, and I usually start with something to break the ice, because they say, go tell them what they're supposed to do and not supposed to do, which obviously anybody has kids, so that's not ever going to work. But I say, how many people in the room have ever ridden a roller coaster? Because somebody will ask, can I ride a roller coaster? And of course, we're supposed to say no, like that's going to work. And every single kid has raised her hand, to a T. I mean, even though they already have read the same books we have, they said, no, you're not supposed to do that. So we just say, there you go. Okay, I got it. And then we start from there. So, yeah.
Sometimes if you switch from the word exercise to movement, and then say, we think it probably will allow you to feel better and live longer, it'll lower your blood pressure, and it's not dangerous. And I do that a lot. How do you like to move? Do you want to walk? Do you like to swim? It doesn't matter. Give me 30 minutes a day, and you will live 4 years longer in your life. As for the average. Juan has a comment or question.
I have a question about the intensity. I think this might have come from the American Heart Association. So they define moderate exercise as you're walking briskly, but you can still talk. And I find that useful. Do you also find that a way to say this is moderate exercise?
Yeah, I think that's a great idea. And then for isometric training, because so doing things against resistance, again, is low risk. When you use lower weights, you do repetitions, you don't reach muscle fatigue, you don't have to do the Valsalva where you're bearing down, trying to build giant muscles, but you do things in moderation. I've gone away from giving, so someone will say, well, how much can I lift or things, but I don't find that as helpful. Because numbers are not as helpful. It's really as, what do you like to do, and this, and then, because once somebody gets a number, that becomes a barrier. And I've had moms say, well, they said I can't lift 25 pounds. My child's now 26, so I can't pick up my child. And I just say, of course you can pick up your child. You can pick up your child all day and it's going to be fine. But you can see how important those numbers are to people's real lives when they do things like that. Yeah.
I just also wanted to add, like when we redid our physical activity guidelines at the foundation, because people are looking for numbers, we went to you guys, the professional advisory board, and said, maybe we should explain what you're worried about. And so I'm wondering, like, when you talk to the parents, do you start with like, what are you worried about? Then you can go back to
Yeah.
what's real and what's
Yeah.
imagined. Or-
That's a great point. All right, wonderful. Thank you, Dr. Braverman.
Thank you.